it was very nice listening to Luke, who gave really an overview of the vaccines. And I think what we're going to do now is provide maybe another layer to that as we talk about them specifically in relation to COVID in the last year and the whole unfolding over the year. And of course, the big question that we all have, are we there yet? And many people have never heard of NIAC before the last 18 months. And you're absolutely right. I don't think anyone would have known anyone that was on it before then. None of us expected it, but everything changed. So who are we? Well, basically, we're a group of people who've been involved in healthcare and specifically in vaccines for many years. Originally, it started off back in the 90s, trying to collate the information around vaccines into one place that was readily accessible to healthcare professionals. And then it grew in the sense that realized that also the public wanted access to that. So the national guidelines went up online. They're available through the HSE website. And there are representatives from the College of Physicians, College of Surgeons, General Practice, Institute of Obstetrics, National Immunisation Office, and all the different faculties. So the different people that are involved where vaccines are important, for example, occupational health, but also the virologists, the microbiologists, travel medicine, and lay members. So that's who NIAC is. So it's quite a big committee. And before COVID, we would have met every 2 months. There would have been busy times if new vaccines came out or guidelines needed to be updated. And then there would have been the quieter times in between or the still waters. This time has been different because first we went from maybe bi-monthly meetings to every month to every week. And in fact, with a core group meeting many times a week, such that it has essentially usurped everything else that we were doing. It was all a voluntary committee. So people were doing this after their day jobs completely. And that was until last year, just before COVID broke, when it was realized that the demands around vaccines, the need for information, particularly around, for example, the HPV vaccine, had really increased hugely. And at that time, we got a little bit of funding for 2 part-time scientific advisors. Just at that time, I think it was 8 hours per week. So very little to help us. And since then, because of COVID, we're now in a position where we have got a program manager. But what we need to do is actually to move to a fully funded, established NITAG, and that's what is recommended by WHO and by Europe, a National Immunisation Technical Advisory Group, because really the information on vaccines in general, it's not just COVID, it's HPV, it's new vaccines coming in different areas. We've just heard about the malaria vaccine being developed, and all of that needs to be kept under review and the information kept up to date. So at each of our meetings, there are representatives from the Department of Health, the HSE, and the HPRA, because they're the safety agency that looks after that. And underpinning all of that, we also link in now. In fact, coincidentally, just before COVID, it was established a European working group or an EU NITAG to come together so that we could share that not each country was trying to do their own little bit, but we could share the information. And then, of course, we get specialist input as required. And particularly in COVID, we've worked very closely with HIQA in terms of making sure that we've got the right evidence and that it has been synthesized appropriately. So a lot goes into those meetings. Whoops, this isn't moving forward for me. Oh, there we go. But with all vaccines, there are some basic questions, and that is, are they needed, are they safe, and are they effective? And already, as I said, Luke has shown that graphic where we know that, for example, with COVID, and we'll take that as the sample, as it were, that although there's a lot of mild disease with COVID, that some people can get very ill. When we're planning then for any vaccination program, there are some basic guidelines that we have to follow. And there are the sort of the direction, that vision that Sonia talked about. What is the ultimate vision, and then how do we get there? Well, in this case, it was really to prevent morbidity and mortality. That was the most important thing. If you think back to the beginning of it in April 2020, when our ICUs were being overwhelmed, the hospital system could no longer work. So we also needed to protect healthcare capacity. And of course, we want to protect essential services and in as far as possible. And I recognize that there has been so much disruption to normal social and economic life. That was one of the goals as well. But all of that had to be done in an ethical way, recognizing the moral equality of individuals, where everyone really is equal to the other when it comes to health, that we wanted to minimize harm, do it in a fair way. And yes, there was a need to think about reciprocity for those who are putting themselves on the front line. And with that framework, then we approach the questions: are vaccines needed? Are they safe? And are they effective? So let's go back a little bit to the virus. So this is a graphic showing the virus here. It's the coronavirus with the RNA, and that's essentially the blueprint or the architect coming in with the instructions to the cell as to how to make more virus. So the virus comes, it attaches to the cell, it releases that blueprint, and the cell then reads it, makes viral proteins and makes more virus, because that's all the virus wants to do. In that process, the virus is seen and meets cells of our immune system, like those memory B cells, or in fact the acute B cells as well, and the T helper cells, and they start making the antibodies. But also those other cells in the immune system, the cellular cells, they recognize the virus and they have their role to play, including the long-lived memory. So that's what the virus does. So what do vaccines do? Well, vaccines try to mimic that. So what the vaccines do in many different ways, and we'll see that, is they mimic this spike protein that attaches to cell, that goes in, and it gets in different ways with the different vaccines, and we'll look at that in a minute. But basically what it's trying to do is to fool the immune system to respond to the vaccine the same way as it would respond to a virus, and generate the protective antibodies, and also to teach the cells how to respond. Because in a way, this is teaching, these are the front lines, the antibodies, the ones that come quickly. But down behind that, you have the cells that keep, that are the reserve forces, so that they're ready to deploy over time. And here is just a simple graphic. We spoke to this really in terms of what happens as to why we need these vaccines. And it is because although most of the disease will be mild, particularly in the younger age groups, we know that across all the age groups, there can be some who will follow a more severe trajectory and end up getting very sick, ending up in hospital and even dying. And as you go up in age, right from the beginning, that has been the single most important correlate of why we might become severely ill and end up in a bad situation. And likely that correlates with the normal aging of our immune systems to some degree, because there is this concept of immune senescence, whereby we do not respond as well as the younger children. And there you can see how children generally, in fact, have mild disease, whereas when we get up into the extremes of age, it's very difficult to deal with COVID. So then the vaccines came, and we thought it was the beginning of the end, and everybody thought, straightforward, let's do it. Well, that really wasn't the case, because the reality has been more like this. Why so? Because on the one hand, we've had a virus who hasn't played ball. It keeps twisting and turning. It has developed capacity, increased transmissibility. In some situations, some variants, but thankfully, they aren't the most transmissible variants. It has become a bit more resistant. But on the other side, we have the forces. We have an array of vaccines that have been developed, yes, in the last year extremely quickly, but not when you think of it overall, because in fact, people have been working towards this goal for many, many years. And so the platforms were all there, ready to go when they had a new virus that needed a vaccine. So that sense that it all happened in the last 18 months before the vaccines came, actually that was stepping on the shoulders of the giants who had gone before. And in fact, if you were to say how long these vaccines are in development, it really goes back not 10, but maybe 20 or 30 years. So what do they do? Well, here's just a characterization, for example, of the cell. Here are the viruses, and we have a range of vaccines. And all of them, as I say, are trying to do the same thing. They're trying to fool the cell, so they think that the virus is there, and they get the immune system to respond in the same way as it would do to natural infection. Here are some of the ones that you're most familiar with, for example, the Pfizer vaccine and the Moderna vaccine. Now, this was a totally novel technique that had reached readiness to be used in the field. And what it was is the scientists had taken the RNA that coded for the spike protein and actually were able to stabilize it enough such that they could inject it, and it was taken up by the cells and could quite cleanly inform the cell as to how to make their antibodies. Over here, we have the viral vector vaccines. And what they are is basically they're a bit of a Trojan horse because they take another virus, but it's inactivated so that it can't turn over and make more infection, in this case, an adenovirus. And into that, they put the blueprint, in this case, DNA, and then that is given into the cell, which opens it up, takes out the DNA, transcribes it to RNA, recognizes it, and starts making the spike proteins as well. More traditionally, up here, we have inactivated virus, where they take the coronavirus and they inactivate it such that it can't cause infection. And we have Sinopharm and Sinovac. Some of you will have heard of Coronavac, that's the Sinovac. And now we've just got data just this week on a European Valneva that has been formed, and the results from it look very, very promising. And that can be given, so that's a more traditional form. And then over here, finally, we have where you just take a little bit of the protein and you give that. And this vaccine also is probably going to be available early in the new year. This would be more in the technology like our influenza vaccines, a subunit protein vaccine. But all of them are doing the same thing. They're informing the cell how to make the antigen, the protein antigen that stimulates our immune system. So the first step is you have to see, do they work? And what you want if you put them into a study is you want results somewhat like this, where you get those that have the vaccine, whichever vaccine, and they are not having the bad events, and you get those who didn't get the vaccine and the disease is going on. But you want them in that safely, I forgot to move that, that should be down here, the vaccine group, that they are safely protected. So that's an ideal scenario. You don't really expect to get results that are that definite when it comes to clinical trials. But in fact, to everyone's really surprise this time last year, the results that were coming out, whether it was from the Pfizer vaccine or the Moderna vaccine or the Janssen vaccine or the AstraZeneca vaccine, they all showed this wide separation, which really is saying they showed the wide benefit that the vaccines afforded to those who were vaccinated. And we didn't know right from the beginning that there was a differential, because the benefit against someone simply getting a mild disease or having symptoms, though very good, wasn't as strong as the benefit against hospitalization. And I'll come back to that point. But incredibly, against hospitalization, and this was back with our ancestral strain, all of them were almost essentially 100% protective against hospitalization. Now, when you say hospitalization, you know in the real world, nothing is 100%, but they were very, very close. Now, in those trials, that's what we refer to as efficacy. Whereas what we really want to know is effectiveness. So what's the difference? Well, in a clinical trial, you're taking a control set of people, very often people who are healthy, they don't have significant underlying disease. For example, in these trials, there was no one with immune compromise. So it's quite a control setting. And the results that we get from that controlled environment, we refer to as efficacy. What we really want to know is how well that translates when we put it out into the real world, where you're not just dealing with a select population, you're dealing with everybody. And you're also dealing with all the situations of getting the vaccine from where it's made into the arms of the people and what their ultimate response is. And that's effectiveness. But these vaccines held up. And I've just taken a couple of examples here to show you, but it could be, there's several studies that would have mimicked this. Here is from Texas, where they were showing those who were not vaccinated, partially vaccinated, and fully vaccinated in terms of getting COVID, and just showing where the virus levels were going before they introduced the vaccine, and then it fell down. Here's Ireland, when this correlate the numbers of cases of disease and then those as the vaccine uptake was going up. But where are we now? Because we've got 92% of those over 18, and it's probably a bit higher even now, it keeps creeping up, are fully vaccinated. And of the whole population, probably 74%. And the pie chart here is showing you the different vaccines that have been used, predominantly Pfizer, but a good segment of AstraZeneca, and then some of the others. So, and yet, what's happening? And I suppose this is what's really topical, and what we couldn't have predicted when this session was planned. But what we've seen most recently is this upswing in cases that has even got a little bit more exacerbated in the last days. And we heard, Leo Varadkar talking about, are we in for twin peaks? So why? Well, there are a number of contributing factors, and to try and tease it out, I divided it in this way. We have our population, we have the virus, and we have the vaccines. So with the population, we've all heard that there's a large cohort who are remaining unvaccinated, and you're going to have more discussion on that. And it's not in any way to vilify, as some have said, we're doing those who are unvaccinated, or stigmatize them. We do not want that. It's trying to understand the myriad of reasons that goes into that. Because it can vary from the simple fear of getting an injection, which can be very real, to those who are absolutely adamant that they are not going to go this road. But that is a small minority. And we really want to address the fears and concerns that sometimes can be very reasonable, where people just need more information in a way that they can understand it, and from people that they trust. Now, the other factors, of course, that have gone on as well is that there's been more social mixing. And that has been the message that we're getting as well. We have to recognize that we've encouraged this gradual opening up, but it has, unfortunately, with the current virus, had consequences. Then there's simple facts that sometimes we forget to do, the things of sanitizing our hands, or using our masks. And we know that this virus is transmitted in a number of ways, not just by hand contact or by respiratory contact, but to a certain extent, especially in closed environments, it may be transmitted in airborne as well. And so we need to tackle on all those fronts, remembering to have good ventilation and do all the other things. But what that has done is that the force of infection in the community has increased. There are a lot more cases circulating. And what that will do is it will pick out those who are vulnerable, those who maybe couldn't respond to the vaccine, or those who are unvaccinated. And we've seen that result in the hospitals today. What about the virus? Well, there have been changes there too, because we've had the Delta virus. First, it was the Alpha virus, and that had some increased transmissibility. And now we have the Delta virus, which is even more transmissible, but fortunately isn't really associated with any more serious disease. It's just that it is affecting more people. Now, the Beta virus was a little bit more resistant to the vaccine, but fortunately, it didn't get that increased transmissibility. So it hasn't become a real problem, and Delta has been to the fore. And you've heard Luke say, well, maybe this is a relatively good thing in the sense that Delta has keeping its place and we're not getting more resistant virus coming in. But that's not to say it can't happen. And then what about the vaccine? Well, some people haven't got the capacity to have a good response to vaccine. For example, those who are immunocompromised. Now, I know in the media in the last couple of days, there are people talking about Colin Powell and seeing that as a reason why he shouldn't get vaccinated. But let's talk about that. He was fully vaccinated. He was 84 years of age. He also had underlying disease, multiple myeloma, and he was on immunosuppressive therapy. So in fact, he is very much the type of person that we would recognize that we need to protect by the rest of us reducing the transmission of infection and the circulation in the community, because vaccines alone will never give that 100% protection to 100% of the people. And then the other factor, we know that there has been some waning in our immune response to the vaccine, but we're going to look at that in a little more detail. This is just looking at sort of the population, and this graph just came out this week, so there's some very topical data there. But you know, what's happening? Why is this increased circulation happening? Well, I just picked out a couple of points to highlight for you. People worry about schools, but actually look there, that's when the primary schools closed. It was after the schools closed that there was the first uptick, because that's we're all beginning to get together again, the beginning of the summer holidays. There's our increase in outdoor. That's when we started outdoor dining. There's our indoor dining. There's when the schools open again. And here's our return to the workplace. Now, I'm in no way saying we shouldn't have done any of those things, but it's just that when we open up, and we are going to be opening up this time, we have to remember that this virus is canny, it's out there, and we just need to try and think about how we get safely through it and keep doing all the things. Remember to keep our distance a little bit if we can. Remember to keep our ventilation good. And a lot of it has been attributed to the fact that this virus, the Delta virus, is so much more transmissible than others. And this just shows graphically how first we have the Alpha, and here's the resurgence with Delta that in fact has paralleled this increase in case numbers. And it's very difficult to tease out. Is it all just because of the Delta virus? Or is it because our immunity has waned a little bit from the vaccines because we started them, you know, now 10 months ago? So it's a combination. And on top of that, we have brought in the more social mixing. So it's all those factors coming together. But are the vaccines still effective? Well, here's data from the US and showing the numbers of cases of COVID, the different peaks throughout the time. But here we can see in the vaccinated population, the fully vaccinated population, the hospitalization rates. So they have not paralleled the numbers of cases. In fact, in the US, between January and July, those who are unvaccinated were 17 times more likely to end up in hospital. And in June to July, which would be the Delta period, they were still 10 times more likely to end up in hospital. So we're talking a lot about waning immunity. What does that mean? Again, this is a study from the US in a large healthcare system, more than 34,000 individuals for over 45 years of age. This is the change in the variants. Here's the Delta variant coming in. And what we can see here is that the protection against infection, there has been some decline over time due to that combination of factors. And what we see, though, is the protection against hospitalization has in fact been held up very well. And this is data literally just released yesterday, and I thought we'd have a look at it together to see what does it tell us, because this is from the UK, population-based. There are some caveats about it, but they were looking at the different periods between what we call the Alpha period and the Delta period, and what your risk was of having a positive test. Now that's whether you had symptoms or not, but actually getting infected versus developing symptoms, not necessarily hospitalization, but developing symptoms. And they looked at those who were previously infected. Now they couldn't separate out whether they were just previously infected and had got vaccines or not, but previously infected. And we know that natural infection confers a level of immunity. And they looked at whether you had any vaccine, 1 dose or 2 dose, and which vaccines they were. So the messages as we look at it are that the first thing to take home is that if you've got 1 dose of vaccine, whether it's in the Alpha period or the Delta period, whether it's in the Alpha period or the Delta period down here, and 1 dose would have lower protection down in the Delta period, you need your 2nd dose. You need to complete your vaccine to get up as high as possible. The other thing that we can see from this is that the protection against symptoms across the board is higher than against infection. And that's our immune system is very good at protecting our lower respiratory tract. The antibodies work very well there. When we have very high levels of the antibodies, they probably work quite well in our nose, but over time, they don't have the same effect, and so we can get infected. And the other thing that has changed in these 2 time periods is that when we get infected, even if we've no symptoms, our levels of a virus are as high in our noses as they are in someone who had had no vaccine. Now, it doesn't mean we get sicker, but they're higher there, so we can transmit it on. Probably not as effectively because they don't stay as high for as long, so we mightn't transmit as well. But overall, if you've had one dose, you need your 2 doses. And yes, in the Delta period, particularly if you've had only 1 dose, we know, and particularly with the AstraZeneca vaccine, the protection has fallen off a bit, but you've still got very high levels against getting symptoms and even higher against hospitalization or ICU. So where are we now? In April to October, this is looking at our hospitalizations in Ireland, and 40% of hospital admissions and 69% of ICU admissions are in the unvaccinated. Now, when you say 40%, then you say, well, 60% are in those who are vaccinated. But you have to remember that only 10% of the population are not vaccinated. So that's a huge overrepresentation. So those who are unvaccinated are carrying the biggest burden of disease in terms of hospitalization. Only 21% of ICU admissions represented breakthrough infections. What do I mean by that? They occurred in people who were fully vaccinated, were 14 days after their 2nd dose of vaccine. And 97% of them had significant underlying medical conditions, for example, immune compromise, or were older. So these are the people we have to protect. And in terms of deaths, again, the median age was 82 years of age, 50% unvaccinated, median age 82, 66% with underlying medical conditions. So that's who we must protect. So booster doses, are they needed? Are they safe? Are they effective for whom, when, and how acceptable to be? And again, when thinking about booster doses, we always have to balance benefits and harm and think about that ethical framework. And the other thing we have to think about here, and Luke alluded to it as well, is that this isn't just a problem in Ireland, this is a problem globally. And we are a global village. And if we don't do our bit in protecting the world and facilitating that protection to take place, this pandemic will go on even longer. So we do want to use the vaccines to protect our vulnerable, but we want to use them where they're needed and when they are needed. So we can do it. What we recommend is that when you are called for vaccine, be it the primary course or now for the boosters, get vaccinated. Vaccines do save lives. They have saved countless lives during this pandemic. And at the same time, we have to recognize the tragedy of the lives that we have lost. The vaccines are safe and they are protective. And if you need more information, please reach out and seek it from a trusted healthcare provider. There are good websites with good information. They will protect you and they will protect others. They will protect your family and they will protect your community. And they do save time and money, because if we can get the whole thing under control, then economy can get going again. And that is important for health, and they will protect our future generations. So what we need to do individually is keep up our guard, and we can then protect ourselves and our family and our community. And so I would like to acknowledge everybody, and particularly the people of Ireland, in really dealing with COVID and being part of the team that extends far beyond the Health Service Executive or the Department of Health or NIAC or any of those, but really extends out into every corner of Ireland. Thank you.